Hello, and welcome to the Health is Fluid webinar series hosted by ImpediMed. My name is Joanne Yao, and I am the Senior Director of Marketing for ImpediMed. Today's webinar is about the pre-habilitation model of care for the patient with breast cancer. We have two excellent speakers joining us today, Karen Hock and Cari Utendorf from the James Cancer Treatment and Research Center at The Ohio State University. Thank you both for joining us. The webinar will begin with presentations from Karen and Cari, followed by a question and answer session. We encourage you to participate by submitting questions via the Q&A icon on your screen. At the end of the presentation, we will answer as many questions as possible. We will also follow up on any questions that we're not able to address live. We're happy to offer certificates of completion for your participation in this webinar upon request. To request a certificate, you may either respond to your registration confirmation email us at info@impedimed.com, or contact your ImpediMed representative. All webinars are available for replay approximately 1 week following the event. You may find them on ImpediMed's Oncology YouTube channel or visit the newsroom page on our website, impedimed.com. Before we start today's webinar, I wanted to share exciting new data supporting the use of L-Dex for lymphedema prevention. A recently published meta-analysis of 50 studies and over 67,000 patients showed that monitoring and intervention for breast cancer-related lymphedema using L-Dex results in an 81% lower incidence of chronic cancer-related lymphedema than circumference monitoring with tape measure. These results are statistically significant. This further validates the importance of using an objective and validated tool like SOZO with L-Dex in a cancer prehabilitation and lymphedema program. Join our upcoming webinar on March 2nd to learn more. Now I will turn it over to Karen and Cari.
Thank you for joining us today. My name is Karen Hock. I'm the Associate Director of Ambulatory Oncology Rehabilitation at the James Cancer Hospital and Solove Research Institute at The Ohio State University Wexner Medical Center. We will be discussing the prehabilitation model of care for the patient with breast cancer. This is a presentation of our NCCN poster from the 2020 conference. Cari and I would like to thank ImpediMed for this opportunity. Our objectives today will be to discuss the efficacy of a prehabilitation model of care for lymphedema monitoring, how to improve the quality of care for our breast cancer patients, and especially improve quality of life, and the clinical utility of SOZO for assessing secondary lymphedema. Just a little background. As we know, the incidence of breast cancer-related lymphedema varies widely in the literature. This is based on how lymphedema is measured and how lymphedema is defined. There is evidence to support the prospective models of care in patients with breast cancer, and we know prospective models of care are beneficial for other cancer disease groups as well. Lymphedema early detection and surveillance is one component of this prospective care model. As we discuss how we have implemented a prospective care model, we'll talk about our lymphedema surveillance, as well as the functional assessment piece that makes up our care model. Let's talk about prehabilitation. What is the goal of prehabilitation? It's certainly different for different cancer disease groups. With our patients with breast cancer, the establishment of baseline measures is very important. We want to take those baseline measures as early as possible, prior to the initiation of neoadjuvant treatment if possible, and certainly prior to their definitive surgery. But we want to look at those patients with a little wider eye and consider their functional ability and their functional baseline measures. Let's discuss the goals of a prehabilitation surveillance program. It is certainly to establish a baseline that includes function and measures to assist with lymphedema surveillance. We want to proactively identify potential functional side effects of breast cancer treatment, factoring in those premorbid conditions that patients begin their cancer journey with. We want to detect and treat subclinical lymphedema, and now we have the tools to be able to do that. And we want to promote that full return to function that our patients deserve. This time of a new diagnosis is a very stressful, anxious time for our patients. A pre-habilitation visit offers us the opportunity to let our patients know that we're thinking about their long-term survivorship and quality of life. It gives us the opportunity to empower our patients in this stressful time and educate them in the role we can play in their long-term survivorship and early post-op recovery. Let's take a look at a pre-habilitation visit. It is certainly the combination of a functional assessment and our lymphedema surveillance measures. Our functional assessment at the minimum should include shoulder range of motion and look at posture. Our lymphedema measures that we take, we use the tape measure for girth, we use a perometer for volume, and we take a bioimpedance score. Our intervention on this visit is some gentle post-op range of motion exercises that can be done safely if a drain should be in place, as well as posture and postural alignment. We also educate our patients in lymphedema risk reduction. For the prehabilitation visit, we have the functional assessment, we have the lymphedema surveillance measures, but we also need to include a very good review of past medical history, comorbid conditions, understand what's important and makes life meaningful to that patient, their leisure, their hobbies, what are their work and family roles and responsibilities. It's also important that we take time to learn what the planned or potential medical and surgical plan of care will be for their disease, as that will impact our treatment as we move forward. And all of that combined will give us our prehabilitation plan of care. Let's look at a surveillance visit. This still includes a functional assessment as well as the lymphedema surveillance measurements. Our intervention at this point is based on the comparison of baseline measures to new measures, as well as what patients subjectively report, and that can bring us to an early intervention. During the surveillance visit, our subjective assessment can be very important in giving us a picture of how our patients are functionally performing. We need to ask those pointed questions about heaviness or aching in the limb, but this isn't only about lymphedema. They've gone through other treatments, most likely. Are they having falls? Do they have any chemotherapy-induced peripheral neuropathy that's causing a balance problem? Do they now have some limited shoulder range of motion that wasn't present before, but now they're 3 or 6 months post-radiation therapy and things have tightened up? Perhaps since you saw them, they started on their AI therapy and they're having myalgias and arthralgias. As we know, if we don't ask the question, we're not going to know the answer. So we want to look at this surveillance touch point as an opportunity to get an idea of how they're doing in their lymphedema surveillance, but also how they're doing functionally overall. It gives us the opportunity then to again check girth and bioimpedance and provide some education. The use of bioimpedance is part of our surveillance visit. Our surveillance model currently is a 2-year model. We measure our patients every 3 months the first year and at month 18 and 24 in year 2. As with many facilities, our patients sometimes travel a great distance, so for all of our patients, we try and schedule appointments to coordinate with another medical appointment in the building. Right now, this is a quality program, so for our surveillance visits, we are not billing unless we initiate an intervention based on our subjective or objective findings. This is our current prehabilitation surveillance algorithm. This was put together by a multidisciplinary committee and has gone through multiple iterations. Preoperatively, all of our patients with planned sentinel lymph node biopsy or axillary node dissections will be sent to physical therapy for the prehabilitation evaluation. Post-surgically, all axillary node dissection patients will return to physical therapy for their post-op rehabilitation and then will be followed with our surveillance model, which is 3-month measurements the first year and 6-month measurements in year 2. Patients who underwent sentinel lymph node biopsy will be referred to physical therapy based on the discretion of their provider. If they do return to physical therapy, we will follow them for their postoperative rehabilitation and enroll them in the surveillance model as well. Implementation can certainly have its challenges. We've gone through many iterations of our algorithm. This has been a practice change for our healthcare team and a practice change for our patients. It has required us to improve our communication pathways with all members of the healthcare team. One of these additions is a best practice alert through our electronic medical record. It's a pop-up box that will alert any member of the healthcare team when they open that patient's chart that they are due for a surveillance visit to physical therapy. This has been a great safety net for us as we work to improve the program and ensure that we are capturing patients at the appropriate points in time. We know there are many benefits to early detection of breast cancer-related lymphedema. It correlates to less physical limitations, reduced medical costs, and most importantly, improved quality of life. We know early intervention can reduce the risk of our patients living with lymphedema long-term. Now I'd like to turn over the presentation to Cari. She is going to talk about the results of our quality project as well as present a case study.
Thank you, Karen, for the great background information. Now we're going to talk through the results from our poster. Please note that these results were polled and analyzed prior to NCCN in 2020, so that would have been in March, prior to March. So they're older results, but I think it has a good representation of our growth of the program and implementation of the model. If we look at this graph here, this shows that we had an increase in percentage of pre-op assessments since we implemented the project or program in September of 18. In that year and month, we started with one physician who was a champion and really believed in the prehab model. And then we grew to be able to connect to 4 to 5 plus surgeons by December of 2019. This data demonstrates that we had an opportunity to treat subclinical lymphedema, but also to improve the quality of care delivered to these patients, which was really, really important. So realizing that this data is about a year old, we can see the growth that has happened. And I suspect if we ran this data again for the next year, for December 19 through December 20, we'd see another continued growth and then maybe a flat line as we assume that maybe we're seeing most of our patients by this point. We can attribute this growth to a couple of things. We formalized a committee in which had all of the stakeholders present. There were NPs, physicians, rehab, administrators, part of this group to try to really increase the number of referrals that we were getting preoperatively for multiple reasons, as Karen had mentioned before, not just the lymphedema surveillance, but certainly quality of life and function after surgery. In addition to that, we were able to speak to groups of physicians to explain the importance of this model of care. All of these efforts made a positive impact on the delivery of care to our patients. This figure, if we take a minute to look at it, these are the individuals who had the pre-op SOZO measure and then later had the post-op SOZO measure, and at some point, either the 3, 6, 9, or 12 month had a delta 6 or a delta 10. If we further look at the delta 6, you can see that of the 16, 14 of them received compression, and then of the delta 10, 5 of them received compression. And this is probably, why we missed some, or potentially miss some would be because the therapist's discretion or the patient refused. And that happened quite a bit. If we looked at the data and the notes, we actually looked through the charts to see what happened. And a lot of times the patients just refused compression because they didn't feel like they needed it or didn't really want it at that time. And now we will take a look at a case. She was just discharged a couple of months ago. This will demonstrate the importance of obtaining the baseline data information and how that implicates further treatment. This is a case of a 55-year-old female, and in 1995 she had Hodgkin's lymphoma with mantle radiation. She had 9 weeks of radiation at that time and finished that up in 1995. In 2016, you'll see that she had optic canal meningioma, and she had excision of that, followed by more radiation to that same region. So in 2019, her oncologist thought it would be a good idea for her to see a physician in our high-risk breast clinic because of the amount and length of radiation that she had had in the past. In 2019, they did a mammo and a breast MRI, and there was no evidence of cancer at that time. And then 6 months later, in 2020, she was seen again in the high-risk breast clinic for a follow-up appointment, standard routine. The mammo revealed the need for a biopsy in the right breast, so then she was scheduled for surgery based on the results of that biopsy for surgical oncology just 1 week after that, and then she saw us that next week for her pre-op assessment that was completed in our department. These are the objective measures from her pre-op visit 1 day prior to surgery. You can see her range of motion is within normal limits, and you can see her bioimpedance score here at negative 2.4, and that is very important to consider at her post-op visit, which you'll see later. You can look at her girth here, unremarkable, maybe noting that her left forearm and elbow are slightly higher than her right. She is right-hand dominant, but she is a golfer and says that she golfs left-handed. This patient decided to have a double mastectomy. Right was obviously needed, and that surgery noted a 5 millimeter sized tumor on the right breast, and the left was prophylactic. She did decline reconstruction at that time. They did end up doing a right deep X dissection, and then she had 2 drains on each side, so 4 total drains. When she was having her follow-ups for her surgical oncology appointments, for her post-op, they noted a seroma on her right chest wall pretty soon after the first drain was removed. So over the course of the next 4 weeks, she had each drain removed, and then she came to see us when that last drain was finally removed. And here are some objective measures from her 4-week post-op visit with us. This was visit number 1, physical therapy evaluation after surgery. She did present with bilateral cording on the right and the left. The right was worse than the left. You can see her range of motion here is pretty limited on the right side compared to the left. And because she had noted and said she had a seroma and that was starting to resolve, and she wasn't quite to 30 days post-op, we did defer the bioimpedance at that time, and we were going to do that at the next visit. Okay, and here we look at her girth, comparing right to left. Remember the X dissection was on the right. She is right-hand dominant, but golfs left-handed. At the pre-op assessment, her left forearm was larger than her right. And now we see that her right forearm is measuring about a centimeter larger than the left. This was that same visit that we deferred SOZO, again, because it was not quite 30 days and not a full 4 weeks after surgery. And so we thought we'd capture the SOZO next session, maybe thinking that forearm was elevated 1 centimeter above the left due to post-op swelling. And so at this appointment, I only taught her postural correction and table slides because she had just had the drains removed. And she was a little stiff and sore. That was our main focus at that session. And in my plan, I had written that I'd follow up with girth measurements and the SOZO obtainment. So if we look then, due to scheduling and her schedule, our schedule, the shutdown of Ohio, we had a delay in ability to see her. So about 2.5 months after surgery, we saw her again. You can see her range of motion is dramatically improved, but unfortunately, you can see that her bioimpedance score is now 12.4. At pre-op, you can see here in the graph to the right, it was negative 2.4. So in this time frame, she did go to the driving range. As I said earlier, she was an avid golfer. Went to the driving range and then noted that when she was finished, her hand was swollen. She did not have compression at this time because if you remember, there was a little lag in between the visits. And so we were concerned about this large jump here. If we look at her circumference, equally alarming. Her hand is a centimeter larger, her wrist unremarkable, her right forearm even larger than the 4-week post-op assessment, and then her mid-upper arm is a little bit larger. So at this visit, what we did, because she was really adamant about being proactive, we gave her ready-to-wear compression and educated that because of the 2-centimeter difference in the forearm, that I would recommend a custom flat knit compression garment, and plus the hand. I didn't take pictures of the hands, but the 1 centimeter doesn't seem alarming, but it definitely was very visible. But she wanted to be proactive and get something that day, so we went with a 20 to 30 ready-to-wear compression. She fit nicely into it. She wore that, but we did also, as I mentioned, measured for a custom class 1. I threw in the tribute. She was covered at 100%, and again, she wanted to do everything possible, so we went ahead and measured for the tribute. And on the custom daytime, we did add a dorsal pad on the right glove. We did do a glove for the individual fingers because they did appear to be a little swollen. The dorsal pad to add extra compression to the back of the hand, and then the digit spacers in the tribute again to give more compression to the back of the hand than you would maybe get without. At this session, I also taught self-MLD and lymphatic drainage exercises. She came to us again about 1.5 weeks after wearing her custom daytime sleeve, and then she returned with these measurements. So you can see here that her hand is much better, her wrist is even better, her forearm stayed about the same, and then her mid-upper arm stayed about the same as well compared to the last visit. But what's really important here is her bioimpedance score, which is negative 0.5. At this time, she was not wearing her tribute because she didn't actually know how to put it on. I did order an outer jacket, so she assumed that went on first. Once at this visit, we talked about the proper way to wear it. She brought it in, demonstrated how to wear it. She was able to understand that she would go on. After visit 7, we talked about how to appropriately wear the tribute. She was going to go home, wear it properly, and give it a try to see if it made any difference. At visit 8, 5 months after surgery, you can see these numbers on the slide here. Her forearm has stayed about the same, a little bit larger than the left, but not a 2-centimeter difference. And then you can also see that her SOZO score has stabilized and stayed at negative 0.5 for the last 2 visits. In case you were curious, here's her range of motion at that 8th visit, which was remarkable. If you remember, post-op right arm was 110, both in flexion and abduction. She did have axillary cording in bilateral axilla, with the left almost completely resolved by the time we discharged her. So we look at the overall graph here of her SOZO score. Her pre-op is listed there. Her post-op is there, but it's repeated again. I repeated it the same day because I wanted to make sure that 12.4 wasn't an error. We emptied pockets, she voided. I made sure that she didn't have any jewelry on, no metal, repeated the score and got the same. That was really just because I wanted to make sure that large jump wasn't attributed to anything else beyond the increase in hand swelling. Then you can see at post-op visit 7 and 8, post-op 8 was done just to see, because her and I were both really curious how that would be. The post-op 7 was 1.5 weeks of wearing consistent daytime compression. And then post-op 8 was about 5 months after surgery, but then 2 months of wearing consistent compression. And this patient actually came to me in early December because she was in the building and wanted to say hi. And she was very pleased and happy to report that she was consistently wearing the nighttime, but she could go a day or two without her daytime compression, and her hands looked great. She didn't notice swelling. She was back to full function. She's not golfing right now because it's winter, but that she feels like she can be a little bit more flexible with her compression, and she was very pleased at the progress that she had made in therapy. And I think this is a really good case to just demonstrate the importance of the pre-op assessment. Had we not had her baseline, the 12.4 would have been alarming, certainly, but we wouldn't really have a good understanding of what her baseline SOZA was. And we were able to, add that pre-op, talk about the importance of seeing us post-op. So when she got that final drain removed, she was able to come see us sooner than some people might have been able to get in. She was advocate for herself and was able to tell her physician that she really wanted to see physical therapy. Let's go over some conclusions here. We know that the literature really supports post-op surgical physical therapy interventions, and now we are seeing an increase in it supporting the prehab model of care for many cancer disease lines. But again, it's really important to note that it's not only for the lymphedema surveillance. It's important to go over their functional baseline, functional range of motion, talk about the importance of upright posture after surgery, and just ensure that their overall function is as good as it can be prior to surgery. We really want to empower the patients to be active participants in their care. Just like in the case, we were able to see our pre-op, express the importance of her advocating for herself, which is exactly what she did to come see us, and then be proactive with her compression when her bioimpedance and girth were abnormal. Now we'll allow some time for Q&A. Thank you.
Hi, everybody. Hi, Karen and Cari. Thank you so much for that presentation. If you wouldn't mind coming on video and off of mute, we look forward to having a question and answer time. We have a number of questions that have come in already. For any of you who would like to submit a question, please click the Q&A icon at the bottom of your screen, and you can submit a question. If we do not have time to get to all the questions in the next 30 minutes, we will follow up on any unanswered questions. So this is awesome. We have a lot of questions coming in. So let's start with the beginning and your pre-op visit. Who attends those visits? We're getting some questions about that. What therapy do you perform and how do you bill? So you talked about you have your pre-habilitation visits open to patients with planned sentinel node biopsy or lymph node dissection procedures. And we have a question, what about patients slated to get axillary radiation?
So I'll take that one. Ideally, if we are seeing patients at the point that we would like to, which is prior to any real definitive treatment, then it would capture our patients that will move on to radiation, axillary radiation. Our goal is to really look at these patients, like I said, with a wider eye. So if they come and see us and they're being scheduled for surgery, what else is coming down the road? And if we see that radiation piece, then we know we're going to be looking for some other possible side effects of radiation down the road. I'm not sure if that answered the question, so please type in again or ask or clarify a little bit.
Thank you. Let's see, when you have your pre-habilitation visit, we're getting some questions about coding and billing. Do you how does that work as far as coding and billing for pre-op visits? Most of our audience is used to post-op visits. How do you handle pre-op visits?
You want me to take that one? Cari, you want to take that one?
I can take it. That's okay. Yeah. Sure. The pre-op visit, we definitely bill the evaluation because, as Kieran spoke, we do a comprehensive evaluation looking at a number of objective measures, but then subjective history. Doing the SOZO, we're doing girth measures at that time. So if we feel like we spent more than the evaluation time, then we will bill appropriately depending on what we do. If feel like we're doing a lot of self-care, a lot of education goes into that visit about what lymphedema is, potential risk factors. Sometimes we get a lot of questions. And if we feel like we're spending a lot of time answering those types of questions, we will bill maybe a self-care if we feel that's ethical. The other thing too, we do have a set of exercises we teach them. Some, as you know, catch on quicker than others, patients. And if we feel like we spent enough time teaching them the therapeutic exercise, we'll bill a therapeutic exercise. That's primarily the three CPT codes that will bill: the evaluation code, self-care, or TheraX, depending on, again, what we feel is ethical in trying to maximize our time with the patients, but make it meaningful and beneficial for them.
Thank you. And we're getting some questions about your protocol and follow-up. So one of our first questions had to do with the slide that you presented, Karen, about rehabilitation surveillance, and that you ask the patient about symptoms and functional limitations and also new complaints. And you mentioned initiation of AI therapy. And the question was, what is AI therapy? What are you referencing there?
Sorry, we get so used to using our own acronyms. AI therapy referred to aromatase inhibitor therapy, that patients perhaps with ER/PR positive disease would be placed on this kind of therapy. And it has a high prevalence for causing people to have joint aches, muscle aches that really limit their function, and at times can cause them to even dose reduce or be removed from the medication. So when we have patients that are on these drugs, or we know they might be, we really want to educate them on the benefit of exercise. We have a James exercise program that we would recommend for these patients, and that's a one time a week for 4 weeks. They come and we develop a individualized exercise program for them that they can then continue at home. Well, nowadays at home, it could be the gym before COVID, but now it's all at home.
And when you see your patients post-op, are you using any specific quality of life or cancer-related fatigue scales in your assessments?
I can take that.
Yeah, I'll let you go.
So yes, I think it depends on what we're seeing them post-operatively for. If we see that the referral comes in for fatigue, we're certainly doing fatigue scales, either the BFI or some other. There are a couple of other that therapists use there. I know some providers use the Promise 10, the SF36, more global function. And then definitely with fatigue, we'll do a 2 or a 6 minute walk test, a timed minute walk test. And then other quality of life measures, certainly if it fits their concerns. If they're simply coming for surveillance, what we are doing is the lymphedema life impact scale. We really like version 2 best. There's 2 versions, and the second one seems to be a little bit, it's worded a little better. Those are the primary outcomes. If there's limitations, joint mobility, we'll do upper extremity functional index, any of the quick dash. The dash is a bit too long for us personally, but those are the primary outcome measures that we're using.
Thank you. Now, we had a couple of questions about the case that you presented. The first question, Cari, is with regard to the patient, how many lymph nodes were removed on that right arm that you were tracking with L-Dex?
Yes, they 0 of 20 were positive, but they ended up doing a dissection because in surgery they could not localize the sentinel node. So when that happens, they just take them all because they don't want to leave, you know, they don't want to leave anything on the table, so to speak, in there. So they did remove them all because they could not find the sentinel node. But 0 were positive upon pathology report.
Okay, thank you. And did you do any manual therapy for the cording in the arms as part of your treatment plan?
Yes, we do. I did with her very gentle myofascial, just enough to really work that cord specifically. I did teach her self MLD. I believe I did MLD once or twice. Her primary swelling was in her hand. Doesn't say that we shouldn't do MLD, but I taught it. She was doing it really well at home, so it wasn't our primary, focus and treatment. For the cords, though, I was doing a lot of myofascial release and then contract, relax in order to get those to resolve. And she was stretching 3 to 4 times a day at home into specific flexion and abduction.
Thank you. And we have a question about the Delta 6 and Delta 10. I think you were talking about change in L-Dex. What do you mean by that?
Let me take that one.
Sure.
So per the bioimpedance studies and guidance of ImpediMed, they've done the work for us to know that if a measurement changes by more than 6.5 points, that puts us in that yellow area on the graph. And that's where we really should be looking at some earlier intervention for what could be subclinical lymphedema, or what we would know would be subclinical lymphedema. A Delta 10 pushes that patient 10 points above that baseline into more of the red area on the graph. And we'd be looking at likely more swelling or more congestion of the tissue, and we would definitely want to intervene at that point. Hopefully that answered the question.
Well, I think it's interesting. It helps answer the question because we know that the change of 6.5 over your baseline measurement is an indicator of subclinical lymphedema. And we know that from the L-Dex studies. Now, we do have a question about how do you know that it's capturing that change, and in your case, the L-Dex score went up to 12.4, which was almost a 15-point change from the preoperative baseline. How do you know that's caused by subclinical lymphedema and not post-op swelling?
Yes, that is why I waited. If you remember, I stated that I saw her just about, it was like maybe 3 weeks and 5 days. So it was just under 30 days. If I would have taken the SOZO then, I couldn't actually rule out post-op swelling. And that's why I waited a good 6 weeks to do that. And to be honest, she was visibly swollen in the hand. So if she wasn't, which is why I repeated it though too, because I wanted to make sure it wasn't an error that, she didn't have a cell phone in her pocket, because we've seen that happen, that had caused that number to be so abnormal. But that's why we wait more than 30 days. If you look at the pathophysiology or the swelling, the length of swelling could be about 4 weeks, 30 days. And that's why we wait until after that to do the SOZO and make sure we can definitively say it's not post-op swelling.
Thank you. Now, we had a question about once the subclinical lymphedema is identified, is it typical for you to follow the protocol of 4 weeks of daily compression?
I think, at least in my case, I usually will tell the patient to wear their compression daily, especially for target activities, exercise, repetition, heavy lifting, things like that. And then follow up with them at that time frame. Cari, I don't know if you do anything different.
I do 2-week follow-up, and then depending on what their numbers look like, then I'll follow them even more. It really depends on on the patient. But similar, yeah, if it depends on if they have visible swelling. If I can measure it with my tape measure or the perometer, I probably tend to have them wear it all day, the compression, versus with activity. But if it's subclinical without visible swelling, similar to what Karen said.
Mm-hmm. And what about if the patient is undergoing other treatment like radiation? Then do you have the patient wear compression even if they're getting radiation treatment?
Are you referring to, we're assuming that there was a change in their SOZO score?
Yes.
Okay, so assuming there's a change in their SOZO score, and we know with radiation, people can develop some issues with swelling. Yeah, I would have them wear their compression as they undergo their radiation treatments.
Thank you. So I'm just looking through the questions. We're continuing to get a lot of questions around the prehab visit, the amount of time you spend, and the billing. We're getting a lot of questions about that. So would you mind, again, just kind of talking through how much time are you spending with these patients? How are you approaching the billing for that time? How are you, what ICD codes, what diagnosis codes are you associating with that visit? Those are the types of questions that are coming through, and we're getting a substantial number of them.
Okay. Well, we started, as I think we both mentioned, this process has gone through a lot of changes. And initially we had blocks of 30 minutes for these pre-op assessments, which we pretty quickly heard from the staff was not enough time. So now we have scheduled 60-minute appointment blocks for our pre-op patients so that they can adequately assess the patient, do the education. If there's need for any kind of other intervention, because like we mentioned, we don't always come into our cancer journey with perfect health, that we have time to address that as well. So all of that, I think, plays into how the billing goes. We obviously bill for an evaluation, but as Cari mentioned, after that, that might be it. Or if there were other interventions performed, then the therapist may bill accordingly.
So is it fair to say that the billing for a pre-habilitation visit is very similar to the way you bill for a post-op visit?
Yeah, I mean,
Yeah.
in actuality, I think for all of us, we want to bill ethically for what we do and not what we don't do. So I guess that's a fair statement.
Okay.
There was a question you had mentioned about ICD-10 code, and obviously we're using the primary cancer diagnosis, but then there's a couple of others that I've seen people use. If we feel like we're giving a lot of education, we'll use Encounter for Education, and I don't have that number memorized. So Encounter for Education, or if we feel like they're high risk for lymphedema, we will use an at-risk for lymphedema ICD-10 code, which we haven't had, knock on wood, any issues with approval there. I think of the people who are getting radiation, we know ahead of time, chemo, axe dissection, we know they're at a higher risk for lymphedema, and I think it's completely appropriate to use that there for that pre-op visit. I think there's some clarity we should specify. I think some people heard we're not billing. It's the post-op surveillance ones, and I'll be honest, if they come in and they're straightforward, we really don't spend enough time to ethically bill. That's how we feel. If they're great, their SOZO hasn't changed, their girth is great, they don't have any concerns, we don't feel ethical billing their insurance for that. It's really a benefit to the patient because if there is something wrong, then we'll convert that into an evaluation and go more into detail and bill appropriately there if we feel like there's lymphedema or range of motion issues, then we'll convert that appointment and end up billing for that.
Now, do you advise your patients who you identify as high risk for lymphedema any differently from the patients that you do not think are at high risk?
I think I missed part of your question, Joanne.
So Cari was saying that sometimes you identify patients as high risk for lymphedema based on their cancer treatment plan. So my question is, do you give them any different instructions or advice than you give to a patient who you do not think is high risk?
I think the big difference is preoperatively, sometimes we know, or we are fairly certain that a patient's having an axe dissection, or perhaps they're having a sentinel node biopsy. Sometimes when we know that, then I think you can be a little more direct in your education to those patients. Sometimes we don't know, or we know that sometimes a sentinel node biopsy can turn into an axillary dissection when they're on the table. So I think you have to look at your patient and see what amount of information is appropriate at that pre-op visit. Some people are eager to have information, and other people, maybe a little bit it is enough at that time.
Thank you. Now, when you get into your post-op follow-up, we're having some questions about the protocol that you use. So why did you choose to assess patients every 6 months in the second year versus every 3 months in the second year? Could you talk a little bit about how you set your protocol?
Yes, we can. And I have to tell you that it's been changed so much that I don't know if I'm going to be accurate in saying why we're doing 6 months the second year. I think that was input from the multidisciplinary team and from research that we read. So we just felt like we didn't need to bring them in at 4 times that second year, especially because we feel like with the education and our ability to maybe empower them to advocate for themselves would also help us in that way. Cari, do you remember? I'm not really sure how we got to that point.
To be honest, I think it follows what we're doing for the post-op LVBs, right? Is that?
That could be too. You know, we have a protocol for our surgical lymphedema patients, and that is our follow-up with them.
Okay. So it's a standard protocol with a cancer patient or a surgical lymphedema patient. That makes sense. Now, we're getting some questions about setting up your prehab program. Could you guys talk a little bit about how you got it started? Like, did you have a meeting with the physicians? Did you do education with your hospital and your outpatient facility? How did you get it started and get the program off the ground? And what is some advice you can offer folks on the call who are looking to start prehab programs in their practices?
I think we both probably can answer this. We started with the original L-Dex way back in the 90s. So we had some exposure for ourselves and for our medical team at that point. But really, we didn't pick up a lot of steam with this until the new Sozo came out, the nice standing frame. And then we brought it to our physicians, but we had good administrative support. We brought in, we brought the whole team together, and that was really the important piece with that. It takes a lot of patience, or it took a lot of patience, and it wasn't very fast moving. So you have to be determined. I wish there was like the magic wand or the magic words to say how to get a program started, but I think having a champion within the different maybe disciplines. You know, we have a physician who's a plastic surgeon, a microvascular surgeon for lymphedema. He was a champion for us. We have one of our breast cancer surgeons is a champion for these programs. We have support amongst our medical oncologists, our administrator, our APPs, our advanced practice providers. Cari, what am I forgetting?
Nothing there. I think, if I think across the board, we're unique and lucky that we're located in the same building as a lot of the physicians that Karen's talking about. So if you're thinking about starting a program, how can you make it easy for the patients to get to you? If you're not in the same building, is there a way that you can grab that pre-op visit same day? Is there a way that you can grab it if they come back for pre-op testing? So thinking about that flow and making it easy for the patients to get to you and easy for the physicians to refer to you. If we require a referral here at the university for physical therapy. So that's really what generates the scheduling on our end, but understanding your process and how to get the patients to you is important when starting that up. Mm-hmm.
I think one thing that we did try having our bioimpedance measures done in the surgical oncology clinic. And we, at the time, or at least it sounded like a good idea for us. And I think that could work. It didn't quite work so well for us, but I think it's a nice model that, you take someone's weight, you can have them stand on the sozo and, you gather that data. And then, someone assesses that and those referrals could be made then to the appropriate service. But that for our center didn't work quite as well, but I think it is a nice model.
And can you talk a little bit more about your EHR? I think you had best practice and how you use that to flag for scheduling.
So the best practice alert was a suggestion, I think, of one of our APPs. It would be, it's timed so that plus or minus 1 month around that time point measurement. So if it's a 3-month measurement, that BPA is going to fire plus or minus a month around that. And it was when we were first starting this and our process maybe wasn't as clean, if you want to call that, as it is now. This helped us make sure people weren't falling through the cracks because we didn't have our scheduling process down as well. In this way, if a nurse in the surgical oncology clinic opened that chart, this box would pop up and it would give them the notice that this patient is due for a SOZO measurement. So, send them to physical therapy. And we've worked through processes of, being able to see patients same day for those measurements, or maybe the patient would say, well, I can't do it today, but schedule me when I come back for my next visit for whatever. So it's been a nice way to keep this in front of the whole medical team so that everybody's trying to play a part in our process and hopefully to keep us from missing patients.
Okay. So when a patient shows up for an appointment and their chart is opened, that's when the alert comes up?
Yes, and that's through Epic. So depending on what EMR you're using, that was built in through Epic, but just would depend on what EMR other people are using, if that's a possibility and how that would work.
And can you talk a little bit about, how patients have responded to your program? We're getting questions about how do you get patients to come back for their measurements, especially if their L-Dex score is normal for, 3-6 months after surgery. How do you motivate patients to comply and continue to come back for their appointments?
I'll be honest, a lot of the patients are excited. They wanna monitor it. They're very anxious about lymphedema. And I thought when we first started it, patients aren't gonna want to come back
but we make it easy for them. If they already have an appointment in the building, we just say, hey, come see me right after your appointment. Trying to make it so that when they're here, we see them. And a lot of them, I'm sure there are some who don't care, and those are the ones that fall through the crack. But to be honest, a lot of them are really into it and seeing, oh yeah, I'm doing really well. Or with the case, she was really excited. She wanted to see what it looked like after wearing compression to see, did it improve? So that visual, that graph, I always show them that, educate them on the graph, and they get excited with that visual feedback. I don't know if you had anything else, Karen.
I think the other important piece for us was we needed to make it easier for the staff as well. You know, when you're going through your day and someone stops you and says, hey, we want you to measure this patient. We all want to do what's right for the patient, but we all know that sometimes we don't want that disruption in our day. So we've set the schedule up so there are times when a therapist might be open and be able to just take those patients and see them. So we wanted to make it a positive for the staff as well.
Thank you. And we're getting some questions about billing, which I'll address in a minute. But I think before we get to that and close the session, I wanted to ask you, as the therapist treating these patients, what are the benefits you have experienced in implementing prehabilitation programs?
Prehabilitation programs in general it's really been a big positive, I think, for us as a staff and for our patients. We're doing a prehabilitation model of care for a lot of different disease groups or cancer disease lines, and it looks different for all of those groups. But, you know, patients appreciate, you know, when you say, we want you to do XYZ because we know it'll help you get through surgery. We know it's going to help you with your survivorship, and your whole medical team is invested in helping you get through this and have a good quality of life for a long time. So I know I get on my soapbox and I think I'm on it right now, but I feel strongly about the whole proactive prehab vision of taking care of cancer patients.
Thank you, Karen. Cari, do you have anything to add?
I think Karen said it best earlier, is that we don't come into cancer without other issues, right? And so it's an opportunity for us to help them maybe with something unrelated to their cancer that they just were putting off. Or what I see a lot is, well, I'm having shoulder issues, but I'm just putting it off because now I have a new cancer diagnosis. But it gives us that time to be able to help them with other functional abilities or quality of life that isn't necessarily just about their cancer. And that's what I really appreciate, that opportunity to help those patients with that, because it does make a really positive impact on their overall care.
Thank you, Cari, and thank you so much both for your time today and going through all these questions. I know that for the folks on the line, we have unanswered questions that we will get to. And Lisa, if you wouldn't mind advancing the slide. So there's two things I wanted to make you aware of. The first is our upcoming webinar with Dr. Chirag Shah, talking about the new data supporting the use of bioimpedance spectroscopy to identify subclinical lymphedema, and the data that shows that we can actually reduce the incidence of breast cancer related lymphedema using this model of care. Second is we're getting a lot of questions about billing. We will follow up on all of them, both with regard to prehab and also with regard to SOZO and the associated CPT code 93702. We have resources available for you at our website, ImpediMed.com. In the healthcare provider lymphedema page, we have links to our reimbursement services and coding guide. Additionally, we have a past webinar about reimbursement that you can view on our YouTube channel. You can go to YouTube and go to ImpediMed Oncology YouTube channel and find our replays of webinars there. And additionally, don't hesitate to contact your ImpediMed representative, and we can get access to our complimentary reimbursement hotline. We can also offer you consultation in how to set up lymphedema prevention programs in your facility. So thank you very much for your participation. Again, Karen and Cari, thank you for a very informative webinar, and we will look forward to seeing everybody on March 2nd.
Thank you all.
Thank you.